Hello, everyone, and welcome to Heads Up, the official weekly podcast of the National Headache Foundation. I'm Dr. Lindsay Weitzel, migraine strategist, founder of the Facebook group Migraine Nation and Chronic Daily Migraine Survivor. I am here every week with Dr. Vincent Martin. He is the director of the Headache and Facial Pain Center at University of Cincinnati, and he is also the president of the National Headache Foundation. Hello, Dr. Martin. How are you doing today?
I'm doing great. Good evening.
Good evening. So we are snowed in. I'm snowed in here in Denver. So I am talking to you all from my house. So this is awesome. Today is one of my favorite topics in the whole world. It's menstrual migraine and how can we treat it? The reason I like this topic so much is I find that you can improve someone's life so much by just decreasing the amount of migraines around their period. Even if they get them all the time, if you can just help with those ones, it can have a profound effect on their life. So I'm really excited to talk about this. Let's start with, it's a fact that about 70% of all women with migraine get migraine around their periods, get menstrual type migraines. So let's discuss how we know if our migraines are menstrual migraines.
Well, there's two things that you have to meet to establish the criteria for menstrual migraine. First, if you take the first day of menstrual bleeding each month, and then you look at 2 days before to 2 days after, if your headaches occur during that 5-day window in 2 out of 3 menstrual cycles on average, then you would meet criteria for menstrual migraine. And also if you meet the diagnostic criteria for migraine. So really it's actually three criteria that need to be met. And it's actually one of the most common trigger factors for many women that are menstruating. So, women that have not gone through menopause that are menstruating, it's a huge trigger.
Right. So let's talk about what it is about menstruation that causes menstrual migraine. What is going on in our bodies? Is it many things? Is it one thing? And why are we getting this?
Well, the biggest trigger is probably falling hormone levels. And the main hormone is probably estrogen. So around the menstrual period, you get this kind of precipitous decline in the levels of estrogen. And that decline probably, at least in part, triggers migraine. But to think that it's all estrogen is probably simplistic. Because when menstruation occurs and the uterine lining sheds and you get vaginal bleeding, you get release of all these other chemicals like prostaglandins and another one called leukotrienes and so forth that get released into the bloodstream, and that could contribute to menstrual migraine. So if women have really heavy menstrual periods, which can often occur during the perimenopause, right before menopause, that fact alone could trigger headaches. And then there also are low magnesium levels around menstruation, which could trigger menstrual migraine, as well as other factors as well.
Okay. So it's my understanding that in general, menstrual migraines are a little harder to treat than other types of migraines when they compare them in studies. Why is this? Is this true? Can you comment on that?
Well, the studies have shown that menstrual migraine is more refractory to treatment, and the headaches tend to be longer duration. And the reason for that is because not only is it the falling estrogen levels that are probably important, but the low estrogen levels that are maintained for several days around menstruation. So if you treat the headache and it gets better, but the trigger still persists, then you can often have a recurrence of the headache, and the headache may last longer than what one would expect.
Right. All right, well, let's talk about what we can do, because there is stuff we can do. And I have seen people's lives, even in my own life, drastically changed by either getting rid of or minimizing menstrual migraines. So it's my understanding there's maybe 3 or 4 things we can do to specifically attack menstrual migraine. Let's start with just can we use our abortive therapies, if those work?
So abortive therapies are what we call acute therapies. So those are therapies that are only taken once the migraine begins. And the key thing to do when you take an abortive therapy is to take it as early in the attack as possible, because once you allow that migraine to become entrenched in the nervous system, it's much more refractory to therapy. The group of acute medications, or what you've referred to as abortive medications, is most commonly used, is a group of meds called the triptans. And those include things like sumatriptan and rizatriptan and zolmitriptan, et cetera. And those probably are our very best therapies for migraine, but for menstrual migraine. But you can also use the ergots. There's one called dihydroergotamine, which is also very good, or it's called DHE.
Mm-hmm.
Or anti-inflammatories can sometimes be used as well as acute medications. But as I said before, treat early because you're going to get a much better response.
Right. So as soon as you start feeling bad and you know that migraine's coming, do something about it.
Well,
um,
so actually, one other thing too is if patients have only maybe short-lived menstrual migraines that only last for a day or two,
right.
and if they're really well treated, then they don't need any preventative therapy for those. So you may just elect just to treat them with these acute medications.
Right. Well, let's move into this is something I know a lot of people who do this. They use continuous oral contraceptives to try and decrease their menstrual migraines. So let's discuss how that's done and why.
Well, there's a number of different oral contraceptives. There's some that have placebo weeks every month, so for an entire week, and a placebo week is just a sugar pill.
Mm-hmm.
So during that sugar pill, you have high levels during the active hormone times, usually the first 21 days, and then what happens is you take the placebo week, and then you get this precipitous fall in estrogen, which triggers a headache. So one thing you could do, particularly if you're taking an oral contraceptive that has a placebo week once a month, you can just basically omit that placebo week, go into the next pack, and you can do that, omit the placebo week from 3 out of 4 packs, and only use the placebo week after the 4th pack, and then you only really have a menstrual period once every 3 months. There also are some birth control pills that are actually don't have placebo weeks.
Mm-hmm.
They're called extended duration pills, and they may just have a placebo week every 3 months, or there are some where they don't have any placebo weeks. They're just continuous oral contraceptives, and those would be unlikely to expose women to falling levels of estrogen, which would trigger menstrual migraine.
Right. All right. So we've gone over certain therapies, acute therapies. We've gone over using oral contraceptives to avoid menstrual migraine. Let's talk about something I've heard of called mini prophylaxis. What does that mean? What is it about? Does it work?
Mini prophylaxis is just simply where you only take your medications during that vulnerable time period when you could have menstrual migraine. So if you have menstrual migraine that begins, say, 1 day before your menstrual period, and if it's predictable, that's the key thing about mini prophylaxis is if you're going to only administer meds for, say, 5 days a month around your menstrual period, you need to know predictably that when your migraine is going to occur.
Right.
So what you do is you would need to know that approximately 28 days from now, I'm going to have my menstrual migraine. Then you would start a therapy maybe a day or two before the onset of the menstrual migraine and continue it for 4 or 5 days. The most common medications used for mini prophylaxis would once again be the triptans, which are the Imitrex or sumatriptan-like medications. But the ones that are most commonly used are the ones that have a long duration of action. And the two that we often use, one is called naratriptan, or the trade name is Emerge, or frovatriptan, trade name is Frova. And those are given twice a day for about 4.5 or 5 days, starting about a day and a half or 2 days prior to the onset of menstrual migraine. Now, you can also give things like anti-inflammatories.
Mm-hmm.
Those you could actually give even longer than just 5 days. You could even start those a week before you would predict you would have menstrual migraine, and maybe continue that for 4 or 5 days in. You can give magnesium around the menstrual period. So there's a number of different either drugs, minerals, or vitamins that you can give around the menstrual period to make menstrual migraine much less likely to occur.
Okay, so that is mini prophylaxis, and that is best for people whose periods are not only regular, so they know when they're coming, but who knows which day the migraine is going to come around the period. If you're one of those people that your whole life has been like, oh, I know I'm going to get a migraine this day because my period's coming, that might be a good choice for you. My last topic I'd love to discuss is there is some controversy around using at least one of the therapies we discussed, which would be the hormone therapies, in women who have migraine with aura. There's been data in the past that came out that women with migraine with aura can have increased risk of stroke if you give them too much estrogen. So can we address that really quick?
Sure. The fear there is that migraine in general, whether you have an aura or don't have an aura does confer an increased risk of stroke. But patients that have migraine with aura have even a higher risk of stroke than those that do not have aura.
Mm-hmm.
And this has led 3 international groups to recommend not using estrogen-containing products because estrogen itself increases the risk of stroke. And if you've already got an increased risk because you have an aura, then it was thought possibly that would confer an even greater risk. However, if you look at most of the data with hormone replace or with oral contraceptives in patients with migraine, frankly, the increased risk of stroke has been in patients that have used high-dose estrogen-containing oral contraceptives.
Mm-hmm.
So really high. When you look at the data of the low-dose estrogen pills, there doesn't seem to be substantial evidence that those increase the risk of stroke in patients with aura.
Great.
But it's still very controversial. So
Yes.
I don't think we can give you a firm answer in that regard. But there's much debate in the headache field.
Yes, there's a lot of debate, and it is something to think about. But I think what we've managed to get across here today is to think about your migraines, think if there's certain ones that occur with your periods, and think if you could at least cut those out. Try and go see your doctor, maybe talk about some of the things we talked about, and think of how your life might change if at least those ones were gone. So is there anything else you want to address before we go for today?
No, I think this is just a very important trigger in many women, and it can be addressed and can be treated. So you just have to get to the right doctor that knows the different strategies that can be used.
Right. All right. So this is Dr. Vincent Martin and Dr. Lindsay Weitzel signing off from Heads Up, the weekly podcast of the National Headache Foundation. We will see you again next week.